Hi, it's Dr. Centeno, and welcome to You've Got the Power. I'm going to give a short presentation first, as I always do, to kind of get the conversation going. And today's topic is on PRP, how to focus on not getting ripped off by a clinic that's offering PRP, or the converse of that is how to find a clinic that's offering high quality care. And obviously, I'll start there, but you can really ask about this topic. You can ask about anything because it doesn't really matter to me. The goal here is to educate people about lots of things, not just platelet rich plasma and PRP. So, again, I'll start there, but you can ask whatever you'd like. And so, let's get into this topic. It's hard enough as a consumer of traditional healthcare. Let's say you're trying to get a specific traditional surgery or a treatment for a certain problem to kind of navigate our crazy healthcare system. Now, the good news is that in traditional healthcare, there's a general floor uh, under which most providers are not really going to perform. And that's because there's strict credentialing requirements, for instance, to get to work in a hospital or to be able to get malpractice insurance, et cetera. But when we move from that traditional medical care system into things like regenerative medicine, PRP, bone marrow stem cell procedures, and other types of procedures, that strict floor isn't there. So you've got this huge, wide gap between the best performing clinics doing the best things and the lowest performing clinics that doesn't really exist in traditional healthcare. So, and this applies to no matter what you got going on, whether you've got neck problems and trying to get some PRP, whether you've got back problems and a knee problem, a shoulder problem, etc. You're going to be a consumer of regenerative medicine. So there's lots of different things under that umbrella, but today we'll start talking about PRP. So most patients, again, believe that if they get offered a PRP injection, that there's some strict standard that's being followed here. And regrettably, that's really not the case. So not only is there no real standard that's being followed, but a PRP injection at one clinic kind of bears little resemblance to a PRP at another clinic. And so you've got to be an educated consumer to make sure that you're getting the highest quality stuff possible. Now, we're all used to this concept, right, of consumer goods. If you spend more money on something, you'll generally get something that's higher quality. Now, there are times that it doesn't work out that way, but in general, that's the way it works in consumer goods, right? We've got high quality, low price. That's what we're all looking for. We want something that's high quality and doesn't cost a lot of money. But we really recognize that in all likelihood, high quality things are going to cost more and low quality things cost less. And we generally understand that. So, for instance, if we buy some junky thing on Amazon that doesn't cost a lot of money, no harm, no foul, we kind of knew it wasn't high quality despite what the crazy reviewers said, et cetera, et cetera. What we don't really see in consumer goods is what we see in regenerative medicine, and that is low quality at a very high price. So it would be as if that little junky thing you got on Amazon, let's say a chapstick, that should run you $1 for a chapstick, really cost $50 for this chapstick, and it was the same chapstick that cost $1. They just charged 50 for it and someone paid it. So that's what I'd like to talk to you about today, this rare issue of this low quality, high price, which is what we see that's rampant in regenerative medicine. So how can you protect yourself against that one condition, right? Because no one wants to pay a bunch of money for something that wasn't any good. We'd all love to pay, obviously, not much money for the best, but we kind of understand that if we want the best, we may have to pay more. But we definitely don't want to pay a lot of money for something that's no good. So there's really only one way to protect yourself as a consumer right now, because those standards in regenerative medicine don't exist, and that's to get educated. So I'm going to educate you today on PRP and how to be a consumer of platelet-rich plasma. And before we get into that, obviously we all know platelet-rich plasma is when the doctor takes blood and concentrates your blood platelets to enhance healing, and then those are injected in a place that needs to get healing promoted. So that's what we're talking about today, platelet-rich plasma. So there's really these 6 things that we see that you need to look at if you're getting a PRP injection. Candidacy, are you a good candidate for that procedure? Blood draw volume, how much blood did they take? Processing, how are they making the PRP? What kind of PRP is it? Because there's some major types you need to know about. And then what's the dose of that PRP? Because there's nothing in medicine that doesn't have a dose. And how are they getting the PRP finally to where it needs to go? So we're going to go over each of these categories here. So when candidacy is concerned, if you've got mild to moderate disease, PRP generally works well. So if you've got mild knee arthritis, PRP is a good choice. A mild ligament tear, PRP is a good choice. But if you've got severe disease on the other side, something like more severe knee osteoarthritis, PRP is not a great fit. So you got to make sure that you are a good candidate, and that's someone who's got mild to moderate orthopedic problems, not severe ones. So that's the first thing to know. Obviously, if you walk in with severe knee osteoarthritis, you want your doctor to say, you know what, this isn't a great fit for you. Maybe these other things are, but this isn't a good fit. The next is blood draw volume. And this is really a good way where you can tell if you're dealing with someone who knows what they're doing with PRP or a total novice. So if you go in for your blood draw, and let's say they want to treat your knee, and you're an old guy like me, right? You're in your late 50s, you've got some mild knee arthritis, you're getting a knee PRP shot, or let's say you're a CCI patient and they're going to try to treat the ligaments back here. Now, in order to do that, you're going to need to draw a lot of blood. And what I mean by a lot of blood is if they draw one blood tube, you're dealing with a total novice here, meaning that we're talking about 40 tubes, 50 tubes. That amount of blood would be required to treat those kinds of things with the right dose of PRP. So if they're drawing just a couple tubes of blood, you know right away you're in the wrong spot. And to explain that, I'll get deeper into this and talk about dose. Now, processing. There's 2 ways that PRP, once the blood is drawn, can be processed. They can put it in a little bedside centrifuge kit, or they can have an on-site lab. Now, the problem with bedside centrifuge kits, as we get over to dose, is that they frequently can't get to the higher doses that older people require. And that can be done in on-site labs, but you got to make sure you've got a good on-site lab. And that's one of the things we do with our Regenix Network providers. We help them do that and supervise that lab so that they can produce high quality stuff. So an on-site lab in general, if it's properly run, can produce better stuff than a bedside centrifuge kit. And then we get to the 2 different types of injectable PRP. We've got the red stuff and the amber stuff. Red PRP is what's called leukocyte rich. It's got a lot of white blood cells and red blood cells. Amber PRP is what's called leukocyte poor. It means it's got far fewer red and white blood cells. Now, of the 2, amber seems to be the better product for most problems and things. So if you're getting your neck injected or your knee injected, then amber would be the way to go. However, if you're getting something like a spinal disc injected in your neck or back, then that probably should be more red PRP because that reduces the likelihood of a disc infection called discitis. So most of the time it's amber. If you're getting some specialized things, you might want red. And then dose is really where the rubber meets the road and we see the train come off the tracks. And that is that listen, if you're 25 years old, then low dose PRP is as effective as higher dose PRP. But once you get past your mid 30s into your late 30s, 40s, 50s, 60s, and up, you need higher doses. And our research shows that, our published research shows that. And the higher the dose, the better cellular response you're going to get in an older patient. So for most older patients, we're looking at doses of 17 to 20x above baseline, meaning that's 7 times to 20 times more concentrated platelets. The problem is the machines can generally only create this stuff over here and can't really get into these high doses. So you kind of have to have an on-site lab if you want to treat older patients with PRP and do a great job. And then re-injection, right? You've all heard this from me many, many times. So we've got blind, which is not good because you just stick the needle in there and you don't know what you're doing or where it's going. You've got simple ultrasound, which is better in certain circumstances. Then you've got complex ultrasound guided injections where you can inject more stuff. And then you've got dual modality, which is ultrasound and fluoroscopy. And those are the highest level providers that can inject this stuff anywhere in the human body it needs to go, but they're fewer and farther between. So if you want to learn more about this topic, I actually have a blog on this, and that's the blog address. So you can freeze that if you're watching the video after the fact and go to that website, and it'll go in much more depth than we went in today. But that's a good blog to follow up on. So getting to the point of questions now, in summary, you got to be a smart consumer of all medicine. And the problem in regenerative medicine is compounded because we don't have that certification floor. So you're going to have to learn more to make sure you get the best stuff for the amount that you pay. And PRP is a good example of that. So let me open up the floor for questions, whether it's on this topic or any other topic. I want to take some questions now. So I'm going to go to the questions I have and start with those. Regenix, submitted advanced by Harry Winston. Does Algocells in London use the same type of PRP? As we do, yes, they use the same type as we do. They have an on-site lab. They can get to higher concentrations. So that would be a good choice there. And I am going to butcher this first name, so maybe I shouldn't even try it. Shabrajit, I think. Shabrajit. Tell me if I butchered that. PICL procedure, by PICL procedure, atlas misalignment automatically gets back to its position, and what ligaments cause C2 malrotation. Yeah, so let's do some show and tell, because I think this is an important one for people to understand. I know I've talked about it before on this channel, but let's jump into it again here. Let me just pull that up for you so we can talk about the reason why rotation is often seen at C1, C2. And hopefully I can find that blog for you. So let's take a look. Okay, looks like I found it. And okay, so the C1, C2 facet joint is inherently unstable. So what we're talking about here is where C1 and C2 come together, and they come together with a little peg in the C2 bone, and that's called the dens. And everything rotates in C1, so the C1 is connected to the skull around that dens. And then there's a transverse ligament that holds all of that together. And then there are other ligaments like alar ligaments, accessory ligaments that hold those things together. But when it comes to C1, C2 rotating, it's because of this very different joint configuration that C1C2 has. C1C2 basically is a convex on convex joint. So rather than the normal type of joint that you would see, convex concave, that's inherently stable, this convex on convex joint, if the ligaments are loose, one surface goes forward on the other. So you get rotation there. And that's important because it's not rotating necessarily because a specific ligament is loose. It's rotating because the ligaments that are supposed to hold the convex on the convex joint together are loose. So obviously, we're going to want to combine two things. We're going to want to tighten down those ligaments, and then obviously see a provider who can help you get this back into alignment. So that's really what we're talking about here. It's been advanced by Sherry Scott. When you say substandard PRP, do you mean less effective or somehow dangerous, like contaminated? Well, so certainly there could be the risk of contamination. And so that's theoretically possible. So you always have to worry there. For instance, we make our PRP in a CGMP class clean room. So obviously that's a number of levels above just making it a little bedside centrifuge. But I mean more from the standpoint of the PRP is not as concentrated as it needs to be, and the doctor doesn't understand how to get it where it needs to go. So you can't inject PRP in one spot and have it magically go to another. It has to be exactly placed where it needs to be. Retvati, how many days will it take if I want to get complete evaluation and then discuss all the treatment options at your clinic? Usually, Retvati, what we do there is we will do that over telemedicine first to make sure that you're a good candidate for what it is we do. So that would be reviewing all of your images. That would be talking to you about what's going on, have you filling out certain forms, reviewing your medical history, etc. And then if you're a good candidate for what we do, you can certainly come out and we can decide exactly which treatments you need. But we try to do as much of that ahead of time so that we can make the most of the time that we have together here in Colorado. Hello, could I ask about invitation for visa to US from your clinic? I've not received telemedicine yet, but I'm going into the nearest time. I also found crowdfunding is financial relief. Yeah, telemedicine is the place to start, meaning that we get on a video link like this, we look at everything. I wouldn't want you to come here without a telemedicine visit, especially from Eastern Europe. So that's where we need to start to make sure that you're a good candidate for what it is we do, and that traveling all this way is the right move for you. Ravati, can PRP start helping with all problems in ligament sprains and strains, muscle tightness, disc bulges together in one treatment, or do you have to go for several rounds? I'm a whiplash patient. Yeah, so all of those different things can be treated at the same time. It just depends on obviously what needs to get treatment. So for example, injured tendons and ligaments and the disc could all theoretically be treated at the same time. There'd be no reason to only treat this one or that one. Unless there was some problem with how the patient tolerates this type of injection-based treatment. But if there's not, then we generally treat everything at once. Thanks, Ravati. Okay, guys, so any other questions I can answer today, whether it's about PRP, whether it's about other things, happy to answer those questions. Just type your questions in, no matter if you're on Facebook or on YouTube, happy to answer those. Kelly, can I send you my imaging on CD-ROM, see if I have CCI, have upright and supine MRI, and flexion and extension? Sure, Kelly, what we normally do there is you can either physically send us the CD, or oftentimes it's easier just to use a file uploading service. but either way. And then we will get on a telemedicine link to try to look at those images with you, look at your other history to see if you have CCI, meaning that our focus is symptomatic CCI, meaning that if you've got extra motion up here, we want to know that that's causing your symptoms. Meaning just because you have extra motion up here doesn't mean that that's causing your symptoms. So we've got to get to that point in order to see if this is a good fit. So the best thing to do would be to go ahead and book a telemedicine appointment so we can see if you've got CCI and if that's a good fit, and if it looks like your symptoms are probably coming from that CCI. Cat, going to Denver Monday, will high altitude help my platelets production or no? Cat, generally what happens is if you're here at higher altitude, we're only about 5,000 feet, goes up obviously much higher in the mountains here. But with a higher altitude, what happens over the first couple days is that the patient dehydrates. So that means that you pee more to take fluid out to concentrate the blood. Now, if you're here for longer, over the course of weeks or months, then you do produce a higher red blood cell count, and with that, probably a higher platelet count. So just realize that at the end of the day, if you're just here for a few days, probably not going to see much change in your platelets. Other questions that I can answer that anybody has, just type those in the comments there. And I'm going to just jump onto another topic if no one's got anything. It looks like we got a bunch of questions come in, but there is one thing I do want to talk about, because I want to talk about this more in depth on Monday, and that's a jugular vein compression due to neck and CCI. So we're going to talk about this more on Monday, but I want to make sure that this is a topic that you know is coming up on Monday, so that if you're interested in CCI and internal jugular vein compression, you know that we're going to be talking about this. I'm going to put together a short presentation on this because I've seen this come up a lot. There's two topics that have been coming up a lot right now. One is spinal cord detethering, which I've talked about already, and the other one is internal jugular vein compression. So we're going to want to make sure that you know that this is coming up on Monday. I'm going to do a whole presentation on it, the research, etc. So that's coming up on Monday. Elvis, hi, I read in one Facebook group today that one has to try activated PRP. Never heard about this kind of treatment before. PRP or PRP, only quality and cells you can change level of, right. Happy Easter, Elvis, as well. So activated PRP, yeah, there's not really any reason to activate PRP. So what they're talking about is that when your platelets see free collagen in your body, so let's say into a ligament tear, those platelets form a clot. And activated PRP would be trying to form a clot before you put the PRP in. And there's really no reason to do that, because if you're putting PRP in the right place, it'll automatically activate. So there's not really an advantage to activating it outside the body for this kind of use with regard to injuries or chronically degenerated places. So not really much help there, even though some providers a while back kind of messed around with the idea. It just doesn't make a lot of sense, because it's going to activate by itself in the body. And what activate means is that it forms a clot and then gets rid of its growth factors, which it's going to do anyway. Allison, is tectorial membrane necessary to inject? The blood below atlas PICL with posteriors included gets all of necessary upper ligaments around skull C0 also. From my understanding, you guys basically get all that's needed. Yeah, so let's see. I thought I had a presentation open on that. Maybe I don't, but let me bring that presentation up. And that's probably a good one to go over a little bit. Okay, let me switch the share here. Okay, so let me make this a little bigger so everyone can see it here. Got to switch that out to this one, and then we'll go to that one. Actually, I'll tell you what, we'll go down here to some of this anatomy. So let's go over some upper cervical anatomy here, because I think this is an important thing. This is actually from a lecture I'll be giving in May to a physician group. And let's go through anatomy. So when it comes to the anatomy on the back side, we've got a bunch of different ligaments in here. If we look at the macro view here to the left, we've got the supraspinous, interspinous ligaments, and up top here, we've got the VDL, and we've got the nuchal ligament. So we're going to get all of these ligaments from the back during a PICL procedure because they're important stabilizers that come from the back. And then this is kind of deeper internal ligaments we're looking at now. So just deep to that in the back is the PAOM. And so we will get that. And then there's the tectorial membrane, the cruciate ligament, apical dens, AAOM, SAOL, etc. So we're getting all of these guys. Now, we have to be careful with tectorial, because tectorial is really just a thickening of the dura. So yes, I usually end up getting tectorial, but it's a very, it adds some risk because we can cause a little dural leak there if we get too far in on tectorial. So consequently, usually on first procedure, I don't get that. I'll wait till second procedure. And at the same time, the good news is, since we're filling up this space with clotted bone marrow, we've already treated a dural leak with a blood patch, meaning all a blood patch is clotted blood. So those are the ligaments we're talking about there. And then there's some other ones. Obviously, we talk about alar and accessory ligament. That's how those come in there. And then also these atlanto-occipital ligaments, which are very difficult to inject. In fact, there's no injection technique. I developed it to be able to inject these guys safely because the vertebral artery is close to this atlanto-occipital ligament. So we get lots of different ligaments, and we try to get it all, including tectorial, and especially if we need to get tectorial, but just realize that I'll usually do that more second procedure than first. Kat, how to up platelets while there? Oh, well, Kat, the nice thing about platelets is that they're a renewable resource, right? You've got lots of platelets in your body, and we just take more blood to get the concentration to go up. So let's say we decide that you need 10 times baseline platelets. We'll just take more blood in order to do that. So we've got online calculators we've created. The staff can go in and say, I want 5 cc's of 10 times concentrated platelets. They can enter in your age, your hematocrit, and everything, and find out exactly how much blood they need to take to get there. So we've got that dialed in. You don't need to worry about upping your platelets before you come here. Sabina, can you explain a little bit about the process of how cultured intradiscal stem cells specifically heal the disc, and the difference between Cayman Islands procedure opposed to the same day intradiscal? Also, is there a study out that shows a percentage of success for cultured intradiscal? Yeah, we published a couple papers on cultured intradiscal a number of years ago. So if you were to go to, let me share again here. So if you go to the website, regenix.com, and you were to go under physician resources and then go to published research, that'll take you to all of our published research. And if you head down into the middle here, you're going to see two papers, I think, on the disc procedure. And those are the ones you'd want to click on to look at all of that. Intradiscal injection of autologous hypoxic cultured bone marrow derived mesenchymal stem cells, etc. So that's where you would go to get that information. as far as the difference, there's two different things that we can try to accomplish with injecting a disc. And they're kind of different, and they require different things to get there. Let's see if I can get you there. So if you go to this MRI compilation on my YouTube channel, you'll see there's a whole portion here talking about intradiscal treatment. And if we're talking about trying to get rid of a disc bulge, like this kind of result, then we would need to use the cells down in Grand Cayman. And because those are specially formulated so they can survive inside the disc and try to heal the disc annulus. And in fact, there's a company that's licensed this that's going through phase 2 FDA trials right now. So it's not available here in the US yet, but it can be done down there. Now, if all we're trying to do is to heal a tear in a disc, which is something like this, where we have what's called a high intensity zone or a tear in the back of the disc, then you can either do that with high dose leukocyte-rich, platelet-rich plasma or bone marrow concentrate, which is something that can be done here. So it really depends on which of those two things we're trying to treat. A disc bulge, in which case that's more Grand Cayman, or we're trying to treat just a tear in the disc, which is this kind of thing. Or if the disc is just degenerated and we're treating really the whole functional spinal unit to help degenerative instability, that's again more here in platelets. So I hope that makes some sort of sense. Kat, how to up my own platelet productions for the next super PRP in Broomfield? Again, Kat, really not needed. Now, if you've got abnormally low platelets, that's something you definitely want to talk to your doctor about. But because we can up the blood volume in order to concentrate that down to a higher concentration, you shouldn't really worry about your platelet number or trying to get it any higher, because we can adjust for that on our side. Greg, I had wonderful results with my Regenix on my shoulder. Now my knee is starting to give me trouble. I have cartilage wearing out. Does Regenix offer anything for that? Yeah, sure, Craig. We do a lot of knee work. In fact, I just treated a knee patient this week. So if you go to this Regenix.com website, you go to conditions treated up here, just go to knee. There's a whole thing on knee. I've written a book, the Knee Owner's Manual. There's lots of videos here. There's lots and lots of different discussions on what we treat, how we treat it, etc. So absolutely be glad to take a look at your pictures. Katya, hey, sorry guys, I got a little guy mowing the lawn out there, so you may hear some interference there. Apologize. So Katya, happy Easter, Dr. Centeno. Happy Easter as well. Thank you for everything you're doing and helping us heal. We appreciate it very much. Oh, thank you so much for saying that. You know, it's a the goal is to try to get everyone educated, and you know, as you probably read, if you read the blog, sometimes I get a little I get a little crazy on the blog because I see things out there that I know aren't great, and in order to be able to get patients to understand they're not great, they've got to be educated. So thank you. Kelly, what is the best imaging to do to look for a jugular vein or any vascular insufficiency in the neck? My neurosurgeon recommended a CTA, but she said they won't allow me to rotate my head during it. Yeah, Kelly, that's an interesting one, and I'll talk about that this coming Monday when we're talking about the internal jugular vein compression. A CT venogram is really the best study. There's a couple of clinics trying to offer an ultrasound to do this. Frankly, it's not going to have high accuracy because ultrasound imaging of something like that when you're moving is almost impossible to do, and it's very operator dependent, meaning that If you don't have it just the right way, you're not going to get the right answer. So this is that kind of study that you're talking about. This is a study where there was motion happening. And so here, this person rotated their neck. And so this is the internal jugular vein here. This is C2. You can see that pressing on the internal jugular vein. And this was with rotation. So if we go here and look at this CT venogram, this is the same patient. But you can see that, you know, when they rotate their neck, this one is fine, but this one is compressed. So a CT venogram is the way to do it. Now, if you can't rotate your neck, all you'll get is, do I have internal jugular vein compression or not, with my head not moving? If you can rotate your neck, obviously you can get information like this. And that's going to be more difficult to get done because it's going to require more time, energy, thought. So my sense would be maybe enlist the help of your doctor or, you know, someone like the doctors at our clinic where we can lean on them to do certain things. They tend to listen to us a little better than they do sometimes patients, that this is what we require. So that's where I'd probably start, because my concern is that they just may not want to do it because it just takes more time to do. But you're right in asking for it, because if you're going to see if your internal jugular vein is getting compressed, having motion with that is a better study than one that doesn't have motion. Robin, Stanko Pro place number 1. It's in Fort Myers, Florida. Yeah. That's an interesting thing. Yeah, I think what Robin is saying is what we're talking about here, and that is that you have to be careful with all this stuff because there's so much difference. I know the clinic she's talking about, it operates at a very low level of care and puts a lot of window dressing around it to make it look like it's a very high level of care. But the difference between the clinic she's talking about and other clinics that are working at a high level is huge. And my biggest problem as a doctor is I'll see someone that's blown $20,000, $30,000, $40,000 at this low level clinic, and I'll get really frustrated because at that point they're tapped out. And even though they didn't get any better, and they probably could have gotten better with high level care, they can't afford it anymore because they made a bad choice up front. So don't make that bad choice up front. Thanks for saying that, Robin. Thank you, Craig. Robin, Dr. C, what's the reason Regenix docs can't get flow on one side of a disc while doing a PRP PL epidural? Not sure what you mean there. Do you mean inside the disc or outside the disc? Because if we look at how all of that is put together, let's just look at a lumbar disc because that's going to be easier to look at. You know, you've got the disc itself, and then you have the epidural space. So, you know, there's the inside the disc, and then there's around the disc or around the nerves, and that's the epidural space. So if we're doing a transforaminal epidural and we're going into one specific site, we're only going to get that on one side. Now, if we want to get the other side, epidural, we'll go to the other side. Now, if you're injecting inside the disc, however, you can go to the middle of the disc and get it to flow kind of all around the disc, or you can go off to the right or left of the disc and get it to flow into the disc annulus. So I need to know a little bit more about what you're talking about there, but that's the general concepts, or those are the general concepts. Any other questions, guys, that anyone has out there? Happy to answer anything. Doesn't have to be about PRP or anything like that. You know, the goal is to get your questions answered, make sure everyone is clear on learning what they need to learn. Okay, guys, I think it looks like the questions are slowing down. This coming Monday, realize we'll be talking about internal jugular vein compression because that seems to be a hot topic right now. the goal is to try to get everyone educated on that. Elvis is getting with the question here. Thanks. Just wonder if I'm missing something new, but activated PRP are only a way to make more money. Right, PRP works great. Yeah. So Elvis, activated PRP is really no different than regular PRP. PRP, when a platelet gets activated, it means that it's doing two things. One is it's going to start forming a clot, a blood clot, and that's good because a clot is kind of a biologic scaffold. The second thing that it's going to start doing is to start releasing its growth factors. But as soon as you inject it into the body, if there's any damage in that site, those platelets automatically get activated. So there's no reason to activate it in advance. It's not doing anything for you. And then let me answer your next one. Read more and more from people in Facebook groups that say PRP and also pellet therapy doesn't work at all. It's better with fusion. Yeah, again, Elvis, I think what we're talking about here today is that, the first question I ask a patient when they tell me, well, I had PRP and it didn't work is, what did you get? And then I start asking a bunch of questions. Was it leukocyte rich or poor? What was the concentration? What imaging device did they use to place it? Exactly where did it go? And they can't answer any of those questions. And so more often than not, they're getting a bad PRP shot. So it's not that PRP doesn't work. It's just they got ripped off. They paid a lot of money for someone that didn't really know what they were doing to inject something that really wasn't going to help in the first place. So those are all questions. Now, there's certainly times that PRP fails and you need to go to something else. But more often than not, it's just they got a bad PRP shot. And then as far as fusion, fusion's never an elegant solution to anything, meaning fusion is caveman medicine no matter how you do it. And in fact, I was really encouraged. There was actually a local surgeon that told one of my patients that, listen, if I fuse your neck or your back, that's caveman medicine. I'm happy to do it if you need it. And if there's no other thing I can do to help you or that anyone can do to help you, but don't start with me. What I offer is caveman stuff. And that's very, very true. There is no such thing as an elegant fusion. It doesn't exist. You're bolting together parts of the spine that were meant to move. So the moment you bolt them together, you're going to get overload above and below. So at the end of the day, the goal here is to avoid fusion. Now, if you can't avoid it, it's great to have that option. But that's why fusion is never a first or a second or a third or a fourth or a fifth line treatment. It comes at the very, very end because it's an inelegant thing to do to someone. It's gonna solve one problem and create others. So hopefully the problem you solve is much better than the problem you create by doing fusion. Okay, guys, well, I think the questions have slowed down. So thank you so much for watching today. On Monday, we'll be talking about internal jugular vein compression again at the Centeno Schultz channel, on the Regenix Facebook channel, and on YouTube. So thanks. And Kat just commented there. Yeah, PRP works great. I would agree, Kat. I'm right there with you. I've got a cervical stenosis in my neck. I probably got it injected maybe 4 years ago when it got bad and reared its ugly head, and haven't looked back since. I was a fusion candidate back then. I'm still one today, but at the end of the day, no fusion. So I'm living proof that you don't need to go there the vast majority of the time. Now, sometimes you do. When you do, you gotta take your lumps, but you don't need to do it most of the time. So thanks so much, guys. Happy Easter, and look forward to talking with you all on Monday. And thanks so much for watching, and thanks for your questions. Thank you.